Good evening, everyone. My name is Dr. Andrew Pham. I'm an orthopedic spine surgeon. Tonight I'm going to be giving a talk on living with neck pain, understanding the causes and modern treatment options. I just want to start by thanking the Gildenhorn Institute for sponsoring this webinar. I'd also like to take this time to thank Kathy Pulford and all the staff at Sibley that have helped out with this. And I want to thank everyone for joining me tonight. So the way the format this is going to work is I'm going to give a quick presentation on neck pain. And then at the end of the presentation, I'll be doing a Q&A session. Now on your screens, you should see a section that says Q&A. That is going to be the area that you actually type your questions. You can type them throughout the entire presentation, and at the end, I'll be addressing whatever I see on there. So with that, I'll start the presentation. So talking about neck pain, there's a few things we wanted to cover tonight. So first, we want to explain the anatomy of the cervical spine. And after explaining the anatomy of the cervical spine, we'll be able to kind of better discuss what the causes and the symptoms of neck and upper extremity pain are that people experience. After kind of understanding what the causes and what the symptoms are of neck pain, we'll then move on to treatment discussion. So that we'll start with discussing non-operative treatment options, and then we'll move forward with the surgical treatment options. So to start discussion about neck pain is described as pain in the neck with or without pain referred into one or both upper limbs, and it lasts for at least 1 day. This is a significant issue here in the United States and a very prevalent issue, with 1 in 3 Americans having an episode of neck pain at some point each year. It's the 4th leading cause of years lost to disability, according to many studies. And the annual cost of low back and neck pain in the United States approaches $90 billion. So it's a very significant issue in the United States that many people will experience throughout their lifetime. The good news about neck pain is that most episodes and cases of neck pain can be treated successfully without surgery, though 50% of people will continue to have pain or may have recurrences throughout their lifetime. So because of this, this is an important issue that affects many of us. Now, the symptoms of neck pain are varied and can involve different locations, can be described in different ways, and can last for variable different amounts of time. The main complaint we usually get is neck pain and stiffness. This is usually along the back of the neck, but that pain can also go into the upper back and into the shoulder blades and out into the shoulders. The pain can also involve can go up into your side of your head, and you can have headaches. The pain can also radiate into your upper or lower extremities with certain issues. When severe, problems in the neck can cause changes in your balance and your coordination. It can also cause changes in your bowel and bladder function. So the symptoms are varied and can involve all sorts of things. Risk factors for neck pain. Typically, it has been shown that females are affected more commonly than males. Middle-aged populations are affected more so than younger and older populations. There's a heavy association with more sedentary lifestyles, where people's postures are not as good or where they're constantly spending time sitting at a desk. Smoking and obesity have been associated with higher incidences of neck pain. Obviously, having a history of trauma that may have changed your spinal anatomy may cause neck pain. Sleep disorders, other musculoskeletal comorbidities such as fibromyalgia, rheumatoid arthritis, and then psychopathology, so anxiety, depression, stress, have all been associated with increased rates of neck pain. Now, in discussing neck pain, we need to understand what the causes of neck pain are. In order to discuss the causes of neck pain, we have to start with the discussion of the anatomy. So here are the basics of spine anatomy. We break up the spine into 5 different sections: the cervical spine, thoracic spine, lumbar spine, the sacral vertebrae, which are at the bottom and are 5 fused vertebrae, and the coccyx, which is the residual vestigial tail at the very, very bottom of the spine. So the area that we're obviously going to be talking about here today is your cervical spine, or the upper part of your spine. There are 7 cervical vertebrae. The top 2 are called your atlas and your axis, and this is responsible for most of your flexion, so looking down, extension, looking backwards, looking to your left, looking to your right, and also with your bending or lateral flexion. The other cervical spines are called your subaxial cervical spines, and that's C3 to C7. Those are also responsible for some motion, but again, the vast, vast majority of your motion is going to be dictated by those top 2 vertebrae. Looking at the cervical spine from a side profile view, I like to break down the anatomy into 3 different columns. So in the front column, you're going to have your vertebral bodies and your discs. The back column, you're going to have these pointy bones, which we call the spinous processes. These are the attachment site for your muscles. Also in the back of your spine, you have the facet joints, which is actually the bony articulation that moves across themselves whenever you're bending and moving your neck. And then in the middle, between all of these bones and soft tissue structures, are going to be your nerves. So your spinal cord is the big nerve that goes down the middle of your spine. And then branching out from your spinal canal are going to be your nerve roots, which go down into your arms or go down into your legs. So again, to recap, it's a 3-column system, with the front being the vertebrae and the discs, the back being the pointy bones, which serve as attachment sites for muscles and the joints, and the middle column are your nerves. This is another view from the side, and again, this kind of puts more focus on the facet joints, which again are the bony articulations that slide across each other whenever you're bending and moving your neck. And as we'll discuss later, that can serve as a pain generator. Looking here on the left side of the screen, this is a basic sort of map of what your spinal cord and your nerves are like as it comes out from your brain and goes down your spine. So again, you have your spinal cord, which goes down the middle of your spinal canal, and then branching out from the spinal cord are the nerve roots that go down into your arms and down into your legs. Okay, this is a cross section of what your spine looks like. And again, we have the spinal cord, the nerve roots. This is your disc, and these are the bones in the back that we were talking about that kind of serve to protect the spine and neural elements. This picture here is not necessarily something you have to memorize, but it does tell us that the muscular anatomy of the spine is incredibly complex and complicated. And this is just to remind us that any issue or problems you have with any of these muscles can also cause neck pain. And this is why neck pain can be so complicated, because there are so many different causes of neck pain. Putting this all together, this is an x-ray of a normal spine here on the left and a degenerated spine here on the right. And we can see that there's a difference here, but what exactly are we looking at? Okay, and so this slide is kind of help point out what things can go wrong that can cause neck pain. So when we look at the differences between the two, the first thing we notice here is loss of disc height. So again, in between these vertebral bodies are the discs. And these discs serve as shock absorbers, and they do wear down with time. As they wear down with time, you can have degeneration of the entire spinal elements, and then that can be a source of pain. As the disc wears down, the bone starts to see more load because it loses its shock absorber. And so the bone responds by making bone spurs. So in a degenerated spine, we oftentimes will see these bone spurs protruding from the front, or you can also see them here in the back. Okay. Speaking of things in the back, we also see that the facet joints here are degenerated, so they lack the sort of smooth crispness that we see here. And we can see that the lines here are a little bit darker and a little bit rougher, indicating that you have degeneration in these joints. So instead of having a nice smooth sort of motion whenever we're looking up and down, this patient is likely suffering from some sort of grinding that's occurring back here, and that also can cause pain. The next thing we see in this x-ray is instability. So what we see here is that the back of these vertebral bodies, as indicated by these lines, don't exactly line up. You can see that there's a small step off here. So what's happening here with this patient is anytime they're looking up or down or getting up and moving around, you're getting sort of this front-back abnormal motion of the spine, and we call that spondylolisthesis or instability. So that sort of abnormal motion can also be a pain generator, not only because it's wearing down that disc with time, but also, again, because it's kind of grinding the facet joints. The last thing we look at when we're looking at this x-ray is we're looking at the curve of the spine. So here on the left, I marked with the red line a normal curvature in the neck. This normally arches backwards like this, and we call that cervical lordosis. So that's normal. This is what we want to see in the neck. And you can see with this degenerated spine that the curve is actually straightened and actually kind of tilting forward a little bit in some parts. We call that loss of cervical lordosis or cervical kyphosis. So having this sort of abnormal alignment and curvature of the neck can also affect someone's experience of having neck pain. Now, when we evaluate people for neck pain, we always want to start with a history and physical exam. Through history and physical exam, we can gain about 95% of the information we need in order to diagnose your problems and hopefully help treat you. So in a history exam, in the history, we're wanting to know how long the pain's been going on for, where the pain is at, what other things have you tried to help it, what makes it better, what makes it worse, what other sort of comorbidities do you have. The physical exam, we're looking at where the pain is, what's making the pain worse, what sort of positions in your neck are making it worse. We're looking at your arms and legs, looking for strength, weakness, numbness, tingling. We're looking at how well your arms are coordinated. Once we get through the history and physical exam, oftentimes we get imaging. So we already saw all the information that we're able to glean from getting an x-ray. But if we need more detail about your bony anatomy, we get a CT scan, which provides good three-dimensional views of the bone and the anatomy of the cervical spine. Now, with X-ray and CT scan, that it does very well for bony detail, but it doesn't tell us much about the soft tissue structures in the neck, mainly the nerves, discs, and some of the other soft tissue that lies along the back of the neck. For that, we need an MRI. So an MRI provides great information to tell us what is happening with the discs and the nerves exactly. Ultrasound can sometimes also be used to look at the muscles back in the neck to look for any obvious defects or problems in the muscle. And then other tests that we sometimes use are neuroconductive studies, which is a test that evaluates your nerve and muscle function. And that again can help pinpoint what your problem is and where it's coming from. Now, when I talk about neck pain, I like to classify neck pain into three separate categories. And we'll talk about each of them briefly right now. So the first category of neck pain that I want to talk about is axial neck pain, which is pain that is isolated specifically to the neck and the upper back. There's no radiation to the arms or anything like that. It is simply in the neck and the upper back. There's many different anatomic causes. There's many different causes of this. The first ones are obviously anatomic in nature. We've already kind of alluded to how muscular issues, muscular problems can cause people to have neck pain, but also arthritic and degenerative changes of the spine involving the facet joint or the discs, having any sort of abnormal motion and instability from either trauma or degenerative changes. Tumor can also cause anatomic defects in the spine that can also cause you to have axial neck pain. Other causes of axial neck pain involve biological things such as fibromyalgia or other diseases such as hypothyroidism or rheumatoid arthritis. And then there's the psychological and social aspects, so stress, depression, anxiety. These are all things that have been studied and have been found to increase people's rates of axial neck pain. The good news again about this is that the vast majority of these will resolve within 2 months, though there is a high rate of recurrence. But what we do see is kind of wave sort of distribution of this, where it gets better and then it comes back, and then it gets better and comes back. But most of the time, these can be treated non-operatively and with conservative measures alone. Moving to the next category of neck pain is what we call cervical radiculopathy. So cervical radiculopathy is pain that is caused by actual compression of the nerve roots. So again, the nerve roots are the nerves that branch out from the spinal cord and go down to your arms and legs. If we look here at this picture down here, what we can see is that over here, this is where the nerve root is. And in this particular circumstance, what we have here is we have a disc that is herniated and now is pushing on that nerve. Now, whenever that nerve is being pushed, that nerve goes to a specific area down into your arm. And so what we expect to see in that circumstance is pain, numbness, or weakness involving that particular area of the arm. So the symptoms from cervical radiculopathy typically will follow a specific distribution that correlates with the affected nerve root. So an example of this is that at C4-5, we typically expect, if there's a disc herniation at C4-5, that the C5 nerve root will be involved. And that's typically seen as numbness or tingling or pain in the outside of your shoulder, accompanied by weakness with kind of lifting your arm and also with moving your biceps. Now, cervical radiculopathy doesn't always have to be accompanied with neck pain. So a lot of people with sort of classic disc herniation sometimes will come in without any neck pain at all and really will only be complaining of pain in their arm. And they'll think that there's something wrong with their shoulder or their elbow, when in fact, it's actually a pinched nerve in their neck. Okay? Like axial neck pain, the vast majority of these cases will resolve on their own with time and will resolve with conservative management, though also like axial neck pain, there's a high rate of recurrence. Moving on, this is sort of a diagram that we as spine surgeons look at. And this is not necessarily for you to know, but this is for you to see that the distribution of your symptom, what you're experiencing and where you're feeling that pain or where you're feeling the symptoms can be used to kind of help trace us back to what level is involved. So again, as we see here at the top, Typically, involvement at the C5 nerve root is going to involve sensation problems over on the outside of your shoulder, and then some deficits either in your raising of your arm or your deltoid and your biceps, so curling your arm towards you. Moving on to the last category of neck pain and neck problems is cervical myelopathy. So cervical myelopathy is compression or disease of the spinal cord itself. Again, kind of going back to the nerve anatomy of the spine, you have your spinal cord, which courses down the center of your spine, and then branching off from that, you have your nerve roots that go down to your arms. Cervical radiculopathy is going to involve the nerve roots. Cervical myelopathy is going to involve the spinal cord. And I think we all recognize that the spinal cord is the main nerve that's involved in moving your arms and legs. But specifically, your spinal cord works to coordinate your arms and legs without you having to think about those individual actions. So whenever we're reaching to grab something, we're not having to think about every individual muscle that is firing to get us to grab, the cup or grab that pen. Similarly, whenever we're walking and taking steps, we're not thinking about every individual muscle that's having to fire for us to make each step. Your spinal cord is like a conductor that's kind of telling your arms and legs where to go without you thinking. Therefore, whenever your spinal cord is experiencing pressure or being squeezed, it's not going to do its job correctly. And so the main way that typically presents is with some sort of clumsiness or feelings of instability. So the most common presentation is what we call gait instability, or a feeling of being unstable on your feet. A lot of times people will complain of difficulty walking up and down stairs, tripping and falling very often. This is all examples of gait instability secondary to compression of your spinal cord and your spinal cord not doing what it usually does. When we talk about clumsiness, the main complaint people will have is that they'll have issues tying their tie, buttoning buttons. They're dropping things very often because, again, your arms and legs are not having the same coordination that they're used to. In addition to that, it's not uncommon to have numbness and tingling in the arms and the legs. And whereas with cervical radiculopathy, it follows very predictable and specific distributions. In cervical myelopathy, these symptoms are more diffuse and a little bit more unpredictable. Okay, and then again, you can have neck pain, headaches, and stiffness just like you can with axial neck pain. Now, the reason why cervical myelopathy is important to us as spine surgeons is because the treatment and the natural history of cervical myelopathy is vastly different from the treatment options and the natural history of cervical radiculopathy and axial neck pain. Cervical myelopathy doesn't go back and forth like this. In fact, it deteriorates in what we call a stepwise fashion. So you'll have a period of instability followed by a rapid decline and loss of function, followed by another period of stability, followed by another decline. So that decline is variable between people. Sometimes that decline can represent just some numbness or tingling in your toes or fingers. Sometimes it can represent complete difficulty with walking and inability to control your bowel and bladder. It's very unpredictable how myelopathy works, but we do know it operates in a stepwise fashion. So there are no periods of recovery. It just continues to decline with time. Because of this, we typically say that cervical myelopathy is not something that improves with observation and conservative management alone. In fact, we as spine surgeons say that this is something that is typically managed surgically. And we have done studies on comparing both conservative treatment for cervical myelopathy and surgical treatment for myelopathy. And we have found that surgery is vastly superior to conservative management in terms of long-term outcomes. So now that we kind of understand the basic classifications of neck pain, what the causes, symptoms are, we can get into a conversation regarding the treatment of neck pain. So the primary treatment, with the exception of cervical myelopathy for the reasons we discussed prior to this, is conservative management, conservative non-operative treatment. The principles of non-operative treatment start with physical therapy and medications. So what are we trying to obtain with physical therapy? So the basic tenets of physical therapy is we want to assess and educate. So we want to first evaluate how you move around in your home, how you do daily activities, and we want to make sure that you're using proper body mechanics, that you're utilizing proper ergonomics, and you maintain good posture. After that, we want to strengthen and stabilize your muscles and make sure that you have good neuromuscular re-education. So this involves proper stretching, core and neck strengthening. And then from there, we want to move on to manual therapy if needed. So this is massages, manipulation. And then we want to get you back to functional restoration and have good endurance. So this is making sure that you're doing everything around the home and that you have the ability to do everything that you were doing on a daily basis. So physical therapy is paramount in treating people and hopefully not only getting you better from the current episode that you're having, but also preventing future episodes by giving you the tools you need to keep those symptoms away permanently. The next thing we talk about are medications. So the two medications that I always start with are anti-inflammatory medications, such as non-steroidal anti-inflammatory drugs. The medications that fall into this category are things like Advil, Aleve, ibuprofen, Motrin. These are all over-the-counter medications that we can take to reduce the inflammation. The vast majority of neck pain and cervical radiculopathy are the resultant of inflammation either in the muscles or in the joints or inflammation around the nerves that we can hopefully keep quiet and reduce with anti-inflammatories. Another medication that we can oftentimes give is muscle relaxants. Whenever people are having neck pain, they oftentimes suffer muscle spasms, and so muscle relaxants are very useful in order to reduce those symptoms. For people that are having very severe pain, sometimes we'll give corticosteroids, which when taken orally is a very powerful anti-inflammatory. For people that are recalcitrant to those basic medications, we can sometimes talk about supplementing it with Tylenol, Tramadol, which is a non-opioid analgesic, and then gabapentin, which is an anticonvulsant. There have also been studies that show antidepressants play a role in helping people with neck pain, and that kind of ties into the whole psychological and social aspect of people's experience of neck pain. And then I put on this list opioids because sometimes people utilize opioids, but that's in very select sort of situations. And for me, it's an absolutely last resort because in most circumstances, the risks of opioids and the side effects of opioids far outweigh the benefits of opioids. Moving on from medications and physical therapy, other alternative treatment options that have been studied in the literature and been shown to help in varying degrees are massages, spinal manipulations and seeing a chiropractor, acupuncture, yoga, Pilates, Tai Chi, aquatic therapy, cervical traction, bracing, which a lot of studies have shown has not helped as much, dry needling, which involves placing small needles into areas of the muscle that are resistant to healing and kind of stimulating blood flow in that area, and then psychological therapies, which again ties back to the psycho and social aspect of people experiencing neck pain. People often think as a spine surgeon that I don't advocate for massaging, chiropractic, and acupuncture, but I am 100% on board with it as it has been shown to help in many circumstances. When these sort of non-invasive treatment options, when these non-invasive treatment options don't work, we move on to injections. And so there are various different injections, and we can utilize them in many different ways. But they're principally used as both therapeutic and diagnostic tools, in that they hopefully help you with your symptoms, but they can also help diagnose what the problem is. Because if we inject a certain area that we think is your pain generator, and it does help you, then that kind of confirms our suspicions. Whereas if they don't help you, that kind of tells us that, hey, that is not where your problem's coming from. So the first most basic injection that we do are trigger point injections, which involve direct injection of steroid and numbing medication directly into muscular areas where the muscle might not have healed properly, or if people have muscle knots, this can help break up those knots. Epidural steroid injections are injections that are guided via X-ray into the actual spinal canal itself, and then we inject steroid and numbing medication around the nerves, and we coat those nerves, and so we therefore numb those nerves. So if you're having issues with compression of your nerves, and we do an epidural steroid injection, and your pain goes away, that kind of confirms that that nerve is being compressed, and that's where your problem is stemming from. The last type of injections that we often do are facet joint blocks. So we discussed the facet joints and how they represent the articulation of the bones in the back of your spine that move across each other every time you move your neck up and down. So in a facet joint block, what we're doing is we're numbing up those nerves that sit around those facet joints. If that helps you with your symptoms and confirms that the facet joints are the problems, then what we can move forward with is something we call radiofrequency ablation or rhizotomy. And in that situation, what we're doing is we're using a needle that has ultrasound attached to it. And then what we do is we actually burn away those nerves around your facet joints. You take away the nerves around the facet joints, you take away your ability to experience pain from that facet joint. It doesn't change the anatomy of the facet joint. So if you have arthritis in the facet joint, it's not going to take away the arthritis there, but it can take away your ability to have pain there. Now, these nerves do grow back, so people do require repeat radio frequency ablations, but it is a good option for people to avoid surgery. other emerging treatments that we're still studying that are kind of on the horizon and kind of represent the next wave of conservative spinal treatment options are adult stem cell therapy. So stem cells are precursor cells in your body that have not figured out exactly what they want to become yet. And so they're precursor cells that we can extrapolate from your own bone marrow or fat tissue, and then we can inject it directly into whatever pathologic area you have. And the hope is that the cells can then be allowed to differentiate to regrow things that typically don't regrow. So the big problem with things like disc degeneration and facet arthritis is that you have wearing away of the cartilage in your facet joints, you have wearing away of the disc material, and that stuff does not grow back. And so in using stem cells, our hope is that we can get that material to grow back and hopefully eliminate your pain. Now, the studies on humans hasn't shown that this has been entirely helpful yet, but we still are in the very early stages of this. Another emerging treatment option we have is platelet-rich plasma or PRP therapy. So in your blood, you have what's constitutes as plasma. And in this plasma, you have your platelets, which your platelets are typically responsible for causing blood clots and clogging up any sort of cuts you have in your body. But there's also been shown they've also been shown to have a healing property to them. So in PRP, what we're doing is we're spinning down your plasma, and then we're isolating the platelets, and then injecting those platelets into areas that are not healing or in areas that could use some healing, and the hope is that that can stimulate healing. So this can be useful in, again, facet joint degeneration or degenerative disc disease, okay? Like stem cell, this is also something that is being studied and is on the horizon in terms of being part of the next wave of conservative treatment options. Moving away from conservative treatment options, we want to discuss surgical treatment. Now, like I said before, surgical treatment is the last resort in most circumstances, with the exception of cervical myelopathy, as the studies have shown that surgical treatment for cervical myelopathy is far superior to non-operative treatment of cervical myelopathy. Now, the specific procedure that we perform as surgeons is completely dependent on the nature of the problem. Every person has different causes for their neck pain, and you have to address the proper issue in order to have a successful result. Ultimately, the goals of surgical treatment are, first, we want to relieve pressure off neural structures if that's the problem. This involves removing bone, disc, and soft tissue. We want to eliminate any sort of painful spine movement, and we want to restore your normal alignment. So clearly, going into further detail about that, I want to go back to this picture that we had before. In this picture, what we can see is that the nerve root down here is being pushed on by this herniated disc that's coming out. So when we talk about surgical decompression, what we want to do is we want to remove what's ever pushing on the nerve. So in this circumstance here with the herniated disc, we want to remove this piece of disc, or we want to remove the disc that's pushing on the nerve. Back here, we see that the bone and the soft tissue structure, and here the bone spur is pushing on the nerves. So in this circumstance, we want to remove the bone that's pushing on the nerves. Now, the benefit of that is that by removing whatever is pushing on the nerve, you eliminate the pain generator and you take away a person's pain. The issue with that is that by removing these elements of the spine, you actually cause instability in the spine because you're taking away the supportive structures that usually support your spine. Now, that instability can cause persistent pain, worsening deformity, or it can cause further neurologic issues. So because of this, we typically have to stabilize the spine in some way after performing a decompression. And so the way we stabilize the spine is typically with fusion. So when we talk about fusion, what we're talking about is creating a biologically favorable environment for bone to grow across an area that used to move. And so by causing bone to grow across that area, you now have a limited movement in that area. So with bony fusion, we're seeking to address abnormal and painful motion of the cervical spine that's caused by either us as spine surgeons doing a decompression, or by chronic degenerative changes or structural changes of the spine. We can do this either from the front or in the back. So in the top picture, what we have here is what this surgeon has done is he's removed the disc that's causing compression of the nerves, and then he's put in a piece of bone graft in between the vertebral bodies, placed a plate and screw which holds that area still, and then over time, bone will grow across these two bones and eliminate motion at that spinal segment. You can also perform a fusion in the back. So a fusion in the back is necessary whenever you want to remove the bone off the back of the spine. And in doing so, you destabilize the spine. And so what you do is you lay down some bone graft across the facet joints in the back of the spine, and then you place screws and rods in order to stabilize the spine. Okay, and so in both of these circumstances, what we're doing is we are facilitating bone growth across an area that used to move, and by eliminating that movement, we eliminate pain generated from that movement. You can also address abnormal painful motion of the spine by doing motion preserving procedures. So in these motion preserving procedures, we are maintaining spinal stability and structural anatomy without actually having to fuse the spine. And this sounds all well and good, but we have to do it in proper patients. So if someone is having pain in their neck related to painful facet joint arthritis or bad degenerative disc disease, the last thing you want to do is allow them to preserve their motion in their spine, because they're going to continue to have that pain. So here in these motion preserving procedures, what we've done is we've decompressed the spine, and then we've implanted hardware that allows you to continue to have motion. So the two examples I have here are a cervical disc arthroplasty or cervical disc replacement. So here at the top, what you see is that this physician has removed the disc that's causing compression of the nerves. And instead of putting a bone graft in there that allows for the bones to fuse, they've inserted this metal and plastic piece of hardware that allows you to maintain motion in your spine. Now you can see that if a person here had bad arthritis here in the facet joints, this procedure does nothing to address the facet joints here in the back. So if you were to allow for this patient to continue to have motion, they'd continue to have pain. In this other case, this is a laminoplasty. So in this case, the patient had to have bone removed from the back of the spine in order to open up space for the spinal cord. So what we've done here is we've actually opened up the back of the spine by lifting up the back of the spine, and then we prop open the back of the spine with plates and screws. So now you've opened up space for the spinal cord while still not fusing the spine and allowing someone to have range of motion. So again, the same principle applies. If a person has bad facet joint arthritis, they'd still continue to have neck pain if you perform this procedure. So this is not an option for someone with bad degenerative changes. Now that we've talked about sort of the surgical treatment options, I think it's worth talking about what the best treatment is. The best treatment for issues with the cervical spine and the neck is always going to be prevention. So how do we prevent having continued issues or having issues with the cervical spine? It always starts with proper ergonomics. So you want to make sure that your furniture and the equipment that you're utilizing around the home is ergonomic for you. You want to make sure that you have good posture whenever you're working. You want to take breaks, and you want to avoid sitting for longer than 30 minutes. You want to get up and walk around. And then something that I have to discuss a lot nowadays during COVID is that you want to keep your workstation at eye level. Too many times people are coming in because they're looking down for hours and hours and hours each day. And over time, that takes its toll on your neck and the musculature of your neck. So you want to keep our workstation at eye level. You also want to ensure that you have proper lifting technique. That's pretty much straightforward. So you want to make sure you lift with your legs. You want to keep your back straight, and you want to keep your neck in line with your back so that you're not stooping forward. Diet, proper exercise, and weight loss is paramount to having good spine health. We've already discussed how obesity can play a role in increasing your risk factors for neck pain. And then, like we discussed before, quit smoking. Smoking, obviously, as we know, is bad for your lungs, bad for your vessels, but it plays a role in neck pain and also spine health. So if you're smoking, please quit smoking. So at this point, this concludes my presentation. So at this point, I'm going to be answering questions off the Q&A section off the screen. So if you had any questions, this is the time to type them in the Q&A section. Okay, so someone asked how effective is needling and for what causes a neck pain and how does it work? So what dry needling is, the principle behind dry needling is in people that have muscle-related issues, so muscle strains or knots or something like that. A lot of times these sort of muscle issues in the spine are caused by small injuries of the muscle, and for some reason or another, that area just does not want to heal. And so because of that, what we suspect is that that area is not receiving the blood flow it needs in order to heal, because things in your body need blood in order to heal. So the whole principle behind dry needling is that you're sticking a needle in that area and causing actual micro injuries, which stimulates bleeding in that area. And the hope is that with that increased blood flow over time, that tear or that knot gets better and resolves. So that's how dry needling works. How effective is it? Usually the physical therapists perform this, but I have seen a good amount of people report that it helps. In my own practice, I've seen it be effective about 3/4 of the time, but those aren't official numbers. Okay. Um, so the next question I have is, what is happening when you move your neck and you hear cracking? This is a question I get many, many times in my office. And it's a common thing that a lot of people hear. Now, I think the main thing that people are concerned about is that they feel like their bones are cracking. That's what people think is going on. More likely than not, what you're hearing is actually you're either kind of feeling or hearing some scar tissue in your neck that's moving around, or more often than not, you're actually hearing air coming out of your facet joints. So your facet joints are lined with a capsule. So this is a thick sort of soft tissue that kind of surrounds the facet joint themselves and kind of keeps them protected from other parts of your body. And what's happening whenever you're kind of cracking your neck, or if you're cracking any knuckle and you hear cracking, is you're actually kind of hearing air forcing out of that capsular tissue. I can almost reassure you that you're not typically hearing or feeling your bones move, because any sort of any abnormal motion in your spine that's going to cause bone to grind on bone is going to be incredibly painful. And as we pointed out before, your nerves are kind of surrounded by all of these bony structures. And so it's a very highly regulated area. And so if you're going to have any sort of abnormals, any sort of profound motion in your spine that's going to cause grinding and cracking that you can actually hear it and feel it, typically that's going to result in having some kind of neurologic dysfunction and neurologic injury. So I think you're going to hear any sort of abnormal motion, then you're going to actually, you're actually going to feel these sort of abnormal motions more so than actually hear it. So I don't think that the cracking is actually bony movement. Okay. Does anyone else have any other questions? I'll give a couple more minutes for anyone that might have any other additional questions they want to ask. I'll also take this opportunity to say that my contact information is up on the screen for anyone that wants to email me, or if they want to call my office to schedule appointments. We're always available. So I'll just give another minute or so. Okay. So I have a question here saying, can you speak about spinal stenosis? Okay. So spinal stenosis, stenosis just means tightness around the nerves. So when we're talking about spinal stenosis, that's when I was talking about cervical radiculopathy and cervical myelopathy. So, spinal stenosis is kind of a broad term. When we speak about it specifically as surgeons, we want to kind of talk about where that stenosis is. So if you have tightness around the spinal cord, we'll say that you have central canal stenosis. If you have tightness around the nerve roots that we talked about, those branches that came off from the spinal cord, we call that foraminal stenosis. So spinal stenosis just describes closing in and tightness around the nerves. And again, like we talked about with cervical radiculopathy and myelopathy, these are neurologic conditions where they're going to present in some sort of way where the nerve is affected. So in foraminal stenosis, where the cervical nerve root is being compressed upon, you're going to feel pain, weakness, or numbness in a specific distribution down one of your arms. Whereas with central canal stenosis, you're going to have tightness around your spinal cord, which is going to lead to that cervical myelopathy we were talking about, which is going to present as issues with your balance, issues with your walking, problems with coordination, and diffuse sort of non-specific numbness and tingling. So I hope that answers your question about spinal stenosis. Oh, I guess talking about spinal stenosis and the treatment options, it kind of depends on what the cause is. If the cause of the central stenosis is because you have elements on the back of your spine that's pushing on the spinal cord itself, then you have to address that by removing that bone and then fusing that bone. If it's coming from the disc, then you have to remove the disc and then fuse from the front, or do the cervical disc replacement that we had talked about earlier. Another minute. Thanks for asking questions, everybody. How do you surgically manage osteoporosis? Okay, so the next question I have is how do you surgically manage osteoporosis? So osteoporosis, first and foremost, is a medically treated problem. So for people that are not aware of what osteoporosis is, osteoporosis represents a sort of global loss in bone density. So um, whenever we think about the bone, you kind of have every bone has sort of a harder outer layer, and on the inside is sort of a softer, spongy layer. So in osteoporosis, what we see is that spongy layer becomes less and less dense and becomes a little bit more porous. So the problem with osteoporosis is that it makes you prone to fractures. And so the best treatment for osteoporosis is medical management to increase the density of that bone and to make the bone stronger. I would say that osteoporosis is not surgically managed, but the complications from osteoporosis can be managed surgically. So if you have a fracture in your cervical spine because of osteoporosis, then the way we measure that typically will involve in the cervical spine some type of fusion procedure where we take away movement across that area so that we offload that osteoporotic bone. Other ways that we can sometimes manage osteoporosis in other areas of the spine is when you have a compression fracture in the spine. That is where your vertebral body actually collapses on itself. So again, we talked about how in your vertebral bodies you have a harder outer layer, and on the inside you kind of have this spongy bone. What happens with the compression fracture is that the roof of that block sort of collapses on itself because it's so porous on the inside. So what we can do there is something called a vertebroplasty or kyphoplasty, where we actually fill that area with cement, and so we prevent it from collapsing further and stabilize it. Okay, so that's kind of how, as a spine surgeon, I manage osteoporosis. But again, the primary treatment for osteoporosis is going to be seeing either your primary care doctor or your endocrinologist so they can put you on the proper medications to treat it. And additionally, anyone over the age, especially females over the age of 50, should be taking calcium and vitamin D in order to reduce your risk of having osteoporosis. Okay, the next question I have is, once you have fusion, does it always follow that a patient would develop problems above or below the fusion? This is an excellent, excellent question, and it represents the bane of all spine surgery. So yes, yes, absolutely. The problem with fusion is that whenever you fuse a specific segment in the spine, what you've done is you've taken the forces that used to go across that area and you've concentrated those forces above and below the level of fusion. We call that adjacent segment disease, and it represents, a major, I don't want to say complication, but a major sort of side effect of performing fusion procedures. And so, yes, what happens after we fuse someone is that what we've seen is that over time, the levels above and below the fusion start to wear down. So what we'll see is increased degeneration of the disc above and below the fusion. And we'll also see that the joints behind in the back of the spine also start to wear down with time. The rate of that happening is about 3% each year after the fusion. So it is a very common problem. That's actually why we came up with motion preserving procedures like the laminoplasty and the cervical disc replacement, is because we knew that this adjacent segment disease was a problem and we were hoping to limit it. Now, we have found that these motion preserving procedures, especially the cervical disc replacements, have been shown to help in two-level disease. But in single level procedures, a single level fusion from the front and a single level disc replacement in the front, we haven't seen a statistically significant amount of improvement in adjacent segment rates. But the technology is improving, and it's a problem that we're continuing to work on, and we're doing everything we can to minimize that for our patients. But great question. Thank you for asking that. If anyone has any additional questions or issues, please feel free to email me at the contact information listed below. I'm happy to answer any questions. You can also come into the office and we'll be happy to see you and evaluate you. I don't mind repeating any of this information if you ever want it again. But at this point, I want to thank you everyone for taking time out of their night to attend this webinar. And again, thank you, Kathy. Thank the Gildenhorn Institute. And yes, everyone have a good night, and everyone please stay safe.